Hello and welcome to the prescribing update. I'm Sharon Rees and the copyright for this video belongs to myself. The learning outcomes are to think about the evidence base and safe prescribing for bowel conditions, the most common being diarrhea and constipation. And this is your prescribing updates. We want to think about the therapeutics, what drugs do we use and why, how do they work for these very common conditions. Now, of course, bowel dysfunction is very widespread. It can be very, very distressing for people, apart from, of course, painful with nasty symptoms such as abdominal pain, diarrhea, vomiting, constipation. And we know, of course, that this can lead to things like fecal incontinence as well. So there's a psychological distress element there as well, isn't there? And this has the ability to really adversely affect people psychologically, socially, as well as physically and their well-being. And the nurse-led services are really, really important for support. They're very, very important in terms of education and prevention. You're also in a very ideal position to be thinking about the diagnosis and management as well. And of course, community practitioners are very central to this aspect of care. Since this is a prescribing update, it seems intuitive to think about drugs that also have adverse drug reactions in the gut, causing constipation or diarrhea, and some drugs can potentially cause either, of course. So it's always worth thinking about when somebody has one of these bowel issues, could it be an adverse drug event? And I thought, well, this table just summarizes a few of the common meds that you might find have these side effects. Iron is known to be very constipating. We know that a lot of antibiotics can upset gut flora and produce diarrhea. And while we might be expecting this to be a short-term problem, if somebody already has bowel problems, it might be somebody with background irritable bowel syndrome, somebody with an existing bowel problem, it could exacerbate or set off their existing problem. And then there are drugs like tricyclic antidepressants, that could be amitriptyline, for example, antihistamine drugs that can oppose the rest and digest functions of the parasympathetic nervous system. And if you oppose the digest side of things, you can then slow down the bowel and lead to constipation. Opioids may be one of the most commonly known drug group to affect the bowel, where there are a lot of opiate receptors causing slowing of peristaltic action, increase in sphincter tone. And we actually have a separate section of treatment, if you like, for opioid-induced constipation. So certainly something to bear in mind if you're initiating or involved with opioid treatment. Some antidepressants do, we believe, affect the gut microbiome, but how they actually cause constipation is less clear. And similarly with antipsychotics, the gut is quite affected by metformin, and it is quite common to get abdominal bloating, flatulence, diarrhea, particularly until somebody adjusts. Laxatives, we would expect them to, of course, by addressing constipation, potentially go over the top and then lead to diarrhea. Drugs acting on absorption, which will alter water absorption, like antacids, will also have an effect in the bowel, and obesity drugs too. And just having polypharmacy, being on, we broadly say 5 or more drugs, but for some people, of course, it might be a lot more, can encourage gut disorders such as constipation. We're starting then with diarrhea, which is very often in its acute form because of, say, a gastroenteritis from an organism, a salmonella, an E. coli, that kind of thing. Some people do have more chronic cases of it, and certainly with the more chronic side of it, we're looking for an underlying cause, aren't we? We're thinking, is it irritable bowel? Could there even be cancer if there's a change in bowel habit? What could be causing that inflammatory bowel disease? In the acute sense, Gastroenteritis, very common. Sometimes we pick up things at home, raw, uncooked food. Sometimes it's a traveller's diarrhea from contaminated water, say a giardiosis, something like that. Adverse drug reaction, always there to stress that we must have that in our pot of differential diagnosis where something changes within the gut. Some people get stress, which affects their gut. And if we are releasing a lot of stress, hormones such as cortisol, elements such as epinephrine, this can oppose parasympathetic rest and digest and make the gut very jumpy and irritable and can produce diarrhea. A change in bowel habit or treatment for cancers will often be very irritant to the gut, and that could be chemotherapy, damaging the gut lining, those rapidly dividing cells that are very that are impacted by chemotherapy, but radiation also producing inflammation in the gut, food allergy and food intolerance with inflammation in the gut, and appendicitis as well. Chronic causes, mentioned a couple of those already, but let's not forget diet, celiac. I suppose just thinking about diet, thinking about eating disorders as well, and people that might actually be trying not to absorb food and nutrition. Celiac, and there's those other elements in there as well. Now, very, very bad constipation where feces build up in the rectum and back up can then cause overflow soiling as liquid feces escape around the impaction. So you can have the two existing together. Just a summary here of some of the nasty things that can attack our gut. And rotavirus is more common for children, of course, but norovirus, highly contagious fecal-oral fecal-oral transmission between people. So whole families can come down with diarrhea and vomiting, can't they? And of course, that can be very unpleasant. With respect to bacteria, raw or uncooked food and handling food in the wrong way, cooking it in the wrong way, can lead to Salmonella, E. coli, and Shigella, these nasty bacterial infections. And parasites, if we go abroad, and sometimes bacteria and viruses, of course, can happen when we go abroad, but traveller's diarrhea, things like exposure to Giardia. You can get that in the UK as well, a very, very common parasite that causes this issue for us. Where we have diarrhea, where the gut barrier is compromised, and what that is leading to then is the inability for us to absorb the water back from across the gut wall, which we normally take most of the fluid back. It gets left in the bowel and then of course loosens the stool, producing the diarrhea. So we can lose a lot of hydration through diarrhea, but clearly also vomiting if that's happening as well. And that's not just water, it's the solutes within the water. And we have, of course, a variety of things from small molecules, glucose, amino acids, potassium, sodium, and so on. And hydration, therefore, is a real issue for when we're thinking about the management of diarrhea. It is possible that after being attacked by something, some people's immune system has an overreaction to that, and you can then get reactive complications because the immune system can then go on to attack joints and cause reactive arthritis, can go on to attack the eye, which of course can be very unpleasant. Usually it develops within about 4 weeks of infection and generally will settle down. Sometimes infection like Salmonella can spread and cause problems elsewhere. And certainly if we suspect that there's a very severe case or there's an unusual cause of diarrhea, that's when we might send a stool sample. That's when we might be thinking about antibiotic management as well. And in about 10% of people following a diarrhea caused by gastroenteritis might then have such an upset bowel that it produces irritable bowel syndrome. And you know, that's quite a lot, but 1 in 10 people, it takes quite some years to recover, and about half do recover within 6 years. There aren't many antidiarrheal agents to discuss. Rehydration, mainstay, antidiarrheal meds such as loperamide, and I've got one slide on antibiotics. The practice point to emphasize here is to treat the dehydration. In your regular healthy person, we can advise small sips of water regularly, liquid soup, gradually moving on to smaller meals. But there are going to be some at-risk people, in the case of adults, very old, if we're talking more generally the extremes of age, but also people with long-term conditions such as diabetes, will need consideration as to how to appropriately rehydrate. Oral is preferred, but for some people, if the dehydration is very severe, we may be requiring admission for rehydration and restoring fluid balance. There's also the issue of being able to drink, say, the sachets of oral replacement therapy, and some people can't swallow properly, they can't take in that volume of water. We suggest oral replacement therapy to be taken in small amounts frequently, and the sort of volume would be 200 to 400 mils after each loose stool, with gradual introduction of the usual diet over a few days, avoiding fatty meals as well. And it has been found that early refeeding decreases this leaky intestine that is caused by common things like infection, and that actually helps. But people are often very reluctant to start again because of vomiting and the unpleasant issues of both vomiting and diarrhea, but that does improve matters. The sachets that restore fluid and electrolytes, like Dial-A-Right, of course, help to prevent the very dangerous dehydration, and they reverse fluid and electrolyte depletion. Particularly important at the extremes of age, because this issue can even be life-threatening. And antidiarrheal agents that we're just coming to can also have a role here. If somebody has a severe case or you suspect there's something else going on, then of course referral can be important there as well. We mentioned before that opioids as a drug class can cause slowing down of the bowel, and we can use this therapeutically by agents, in this case loperamide, because we certainly don't want an opioid that causes the pain relief that isn't needed here. Sedation, respiratory depression, that's what we don't want. So what we want is an opioid that doesn't cross the blood-brain barrier, stays in the gut and hangs onto those gut receptors and slows down this very fast transit that's going on, allowing the water and electrolytes to be resorbed and increasing sphincter tone so people aren't on the toilet all the time. And loperamide is licensed for both acute and chronic diarrhea in adults, with a dose range that you see there that would be divided at the higher ranges. And they're also, loperamide is used for fecal incontinence. It can go too far, of course, and cause then constipation and itself produce gut symptoms like nausea and also flatulence, lots of wind and headaches. Now, loperamide can be combined with simethicone. Simethicone is an anti-foaming agent which alleviates trapped wind and bloating, so it improves the symptomatic issues associated with diarrhea. Just to bear in mind, we do encourage people to get things over the counter as and when we believe they will comply and that it's safe to do so. This is one of the things, your Imodium, that you can get over the counter. And loperamide as an antimotility agent is found to reduce the duration of diarrhea by a day, can do that, and increase the likelihood of a cure in 1 to 2 days when given for travelers' diarrhea with antibiotics. Now, the simethicone combination seems to hasten resolution of the problem, and so that combination is considered to be beneficial. But it is important for us to bear in mind that if somebody's got blood in the stool, we're thinking of a dysentery type syndrome here can make that worse. And these are potentially life-threatening issues. So one of the key red flag questions is, have you found any diarrhea in the stool? And if there's a suspicion that there's an inflammatory component to the diarrhea, we don't use loperamide. Pepto-Bismol is a safe alternative if there is inflammatory diarrhea, and then the appropriate investigations would be needed to find out what the cause of it before moving any further with the treatment plan. We don't routinely give antibiotics for regular common diarrhea, but if we know that there's spread of infection and the person is getting signs of sepsis, we of course would initiate that. Extraintestinal spread, if we know that there's bacteria traveling around the body and causing issues elsewhere. If somebody is malnourished or immunocompromised and they have salmonella infection, and then there's the C. diff side of things, which again is separate because it means that we've got overgrowth of C. diff in the bowel in conjunction with the upset caused by something else, and that can be very dangerous, of course. If somebody's recently been abroad, that can also be a sign where we might need to check and get a stool sample to see what's going on. That brings me to the end of diarrhea. There's more to say about constipation, so let's have a think then about constipation. This is a very common condition. The general population is about 17% of people, and we do know that it affects women more, probably by about twice as common in women. This could be because of pelvic floor issues, gynecological surgery as well, pregnancy. Those differences may encourage constipation more in women. And as people age, a lot of things slow down as we age, gut peristalsis among other things, but there's so much then also happens as we age, isn't there? There's the comorbidities that can cause muscle weakness, such as post-stroke. There's the polypharmacy side of things. There can be an issue of mobility and actually getting to the toilet on time, so people holding feces in. It could be a privacy issue. Certainly in care homes and residential care, we know constipation is again even more common, up to 1 in 3 people. So plenty going on. I guess you've got poor dentition potentially, dietary changes, lack of exercise. We could go on, couldn't we? So very, very common generally, and also as we age. But there's also this thing with constipation as to what is being constipated. There are many perceptions of this, because somebody's subjective sense of constipation could be, well, if I don't go every day, there's a problem. And someone else might think once a week or even more is perfectly normal for them. We always inquire into the frequency, what the consistency is like. Is it a fully formed stool? Is it a soft stool? Is it easy to pass? And whether there's a lot of straining, whether there's a sense of incomplete evacuation, are the key things for us to establish before moving on. And whatever the inquiries determine will help us direct investigations and management accordingly. And some things are going to lead us on to diet, lifestyle, exercise, and those sorts of aspects to management, apart from the drugs that may also be needed. The Rome 3 criteria here is what we commonly use. You might use something different, but this is the sort of standard. Is somebody constipated or not? And we can go through these as questions to see what is happening. Just worth saying that constipation is a cause of admission, and the data that you see here is from 2011 with hospital admissions on the y-axis, just here, and age groups. And we can see that at the different extremes of age, this is where we find constipation sitting, the under 9-year-olds, but we're thinking more, we see this increase into middle age, and old age, between 65 and 85 plus, we're seeing these quite high levels for all the reasons discussed before. And we do worry if there's a very weak bowel, and we have to think about bowel obstruction and the implications of that for health if somebody requires admission. Constipation can be acute or chronic, just like diarrhea can, and we will establish how long something's been going on for and what the underlying causes may be. And you can see there's a list here of people at higher risk to watch out for. Lots to do with medicines and their impacts on bowel transit, frail elderly, and immobility is a theme running through here because people of any age can have mobility issues, and constipation is something to watch out for if there's immobility or a real lack of exercise. People in residential care, that can be of any age, and certain conditions that predispose to muscle weakness, certain conditions that slow the gut down like hypothyroidism. There's the learning disability spectrum through to dementia and Alzheimer's, terminally ill, post-op, that's the immobility, the drugs that are being used like opiates, pregnancy, swallowing and dentition issues, and bearing in mind straining where there's cardiovascular issues can induce a coronary event, and confused or depressed people may ignore the sensation requiring defecation. My algorithm here shows for short-term constipation, always be thinking about what's happening to potentially be causing that, what's driving it. Lifestyle measures for diet, exercise, hydration, it's a really big one, isn't it? Keeping people adequately hydrated will always come first and form part of what we do. But thereafter, we're thinking about bulk forming laxatives as an initial step. If they're not working, moving on to osmotic laxatives. If that's not working, we're thinking about moving on to stimulant laxatives, and some people will be on more than one of those levels. Starting then with bulk forming laxatives. And essentially these are soluble fibre, which increases the fecal bulk, and as that distends the colon, that stimulates the muscle contraction that is peristalsis, which moves the stool through the large bowel. This can help offset the effects of low fibre diet, but it is essential to have the adequate hydration when taking the additional fibre, but also throughout the day. And bulk forming laxatives are preferred in some scenarios than others, where there's a low fibre diet, where there's pregnancy, and less preferred in where there is inadequate peristalsis because of an underlying problem, such as if someone's taking opioids. Fibrogel is one of the common bulk forming laxatives that's used, and that's Ispergula husk. This will be a regimen, something like 1 sachet twice daily after food, so breakfast and in the evening. But there are alternatives. So methyl cellulose is a derivative of the starch that is cellulose. It's undigestible. So this stays in the large bowel and it absorbs water into it, it draws water so it can help to soften the stool as well, and stimulating peristalsis gets it all moving. Sterculia is a natural fibre, a natural laxative, which also does this. If somebody has obstruction and you put more bulk into the GI tract, then that is, of course, going to worsen it. So we would never do it where there's intestinal obstruction, where there's going to be difficulty swallowing the fibre that is formed when you mix up these sachets or these solutions. And if there's a very weak bowel, if there's not tone within the musculature, then we won't be able to stimulate the bulk to move through, and that could cause obstruction as well. With fecal impaction, then you could also just add, you could just cause fecal loading, more stool, but that can't move through. These are quite likely to cause lots of wind and abdominal distension, and that can mean some discomfort for people as well. In the context of practice points on what to counsel patients and what to use, these can take several days to have an effect, usually at least 2 to 3 days. And the people must be able to take in the water and have the drink as soon as it's prepared, with additional fluid to support that throughout the day. And that means frail elderly might not remember to do it, might have a problem with getting to the toilet because you're going to need to wee more as well. And of course, there's the effect of the greater stool required. And it isn't to be taken before going to bed, because that can risk obstruction when just lying there still and your muscles aren't encouraging peristalsis. It is bulk forming, so it can make people feel fuller for longer and reduce appetite. And I think I said before, it's not supposed to be used with constipating drugs such as opioids, because you can't compensate when you need to get that moving through with the peristalsis. The next element down on our algorithm was osmotic laxatives, and these increase the amount of water in the large bowel, so they sort of suck more into the large bowel and discourage reabsorption of fluid, so you get distension, greater volume, and that then stimulates peristalsis. So these are essentially poorly absorbed solutes, so they don't get taken back into the body, they stay in the large bowel and pull water into the bowel lumen and getting it all moving from doing that. So Macrogol 3350 will be a very common one that you know about, something like Laxido, increasing the stool volume and getting the colon moving again. So we improve propulsion. One of the big advantages of drugs like Laxido is that we retain, because of this exchange mechanism, serum electrolytes and water. So rather than sucking the water into the stool and softening it and losing that water, there's an exchange. So we're retaining electrolytes. Now, an adult dose might be 1 sachet 1 to 3 times a day, and this comes in a liquid solution as well, which could be 1 to 3 times a day. There is, again, this issue with being able to take in the volume. You have to mix up each time or have the fluid each time, as well as maintain hydration throughout the day. It is important to take this outside of when you're taking other medicines, so not within 1 hour before or after, because this will alter absorption in the gut. This will be a sort of initial kinetic point for other drugs that somebody's taking. It could affect the ability to absorb that drug, which could reduce or increase the efficacy of that drug. Contraindicated for some of the same reasons when there's intestinal obstruction, or if there's any history or current intestinal perforation, a weak or an atonic or a paralyzed ileus as well. Now, some people with inflammatory bowel disease do take Laxido because they do find that they get areas where stool gets stuck because of the inflammation within the bowel. But if people are put on something like Laxido, that's normally done from a specialist perspective. So whoever's managing these inflammatory bowel conditions will advise on what the appropriate, whether it's appropriate and what the appropriate dose will be. If somebody's got an impaired gag reflex, they may not be able to take the fluid, of course, and we don't want filling the stomach and then causing regurgitation of that either. It is common to get abdominal pain, flatulence, diarrhea, vomiting, and anorectal discomfort. We're obviously increasing the bulk here that somebody then has to defecate. And also, because you are altering absorption, it is important to bear in mind that drugs, for example, phenytoin, can not be absorbed as effectively, which could then lead to loss of therapeutic effect. Second line to macrogols is lactulose, and this is where you've got sort of put together disaccharide, a mixture between galactose and fructose. And This consists of when these sugars get into the gut and then they're broken down into certain acids. And so the gut becomes more acidic, which lowers the pH. And as the lower the pH, we get increased gas formation and it stimulates peristalsis. I think I've got a picture. Yes, I have. So lactulose and sorbitol does this as well. So fruits that are high in sorbitol, things like prunes, figs, and dates, they get broken down into these organic acids such as lactic acid and acetic acid. And as the gut pH decreases, we then get this increased osmotic pressure and this water coming into the bowel where the stool is, so it softens it and increases propulsion as well. So lactulose can be taken twice daily, 15 mils, and it takes a couple of days to act. It's very, very sweet. It's disaccharide solution, so it can feel a bit sickly to drink. People always need to keep hydrated throughout the day. Now, some people have an inherited condition where they can't break down galactose, that's this galactosemia, and lactulose won't be appropriate for them, or as it says further down here, if somebody's lactose intolerant, so they can't have dairy products, then they won't be able to take this medicine. GI obstruction and perforation, or a risk of perforation, would also be contraindications to that. Few adverse drug reactions there. The nausea of the sickly sweet solution can be reduced by giving the lactose with water, with fruit juice, or at the same time as meals, and make sure they stay properly hydrated. Otherwise, inadequate fluid intake can mean dehydration because of the bowel absorbing all this extra water. The final level on the algorithm was for stimulant laxatives, and these cause peristalsis by stimulating the colonic and rectal nerves to increase colonic motility. Senna and bisacodyl are examples of this. Now, senna is a herb, and the leaves and the fruit have a stimulant laxative effect. And with senna, the breakdown products cause irritation of the bowel lining, which then stimulates these nerves to start working harder. And you can see here that senna gets broken down into anthraquinone in the large bowel. And anthraquinone is actually, there's several active chemicals here. They're also in rhubarb and aloe, which also have the same effect. And they stimulate the colonic muscles to start moving, to draw more water in. And so more water stays in the gut and softens the stool. And we get this increased peristaltic effect as well. Now, there are tablets, there is syrup, and there's a dose range. It's usually taken in the evening to produce a bowel movement the following morning. And it's worth remembering that all of the stimulant laxatives are licensed for short-term use only. There have been issues with laxatives in general, particularly this sort, for abuse with weight control. So people trying to have food and then try and move the food really, really quickly before nutrients are absorbed in order to exert a weight loss effect. Now, if you keep making the bowel move in this abnormal way, what you find is that the normal controls that stimulate peristalsis start to weaken, and it can mean that the bowel then won't move at all without the use of laxatives after some time. And that's something we always have to be aware of, this link with eating disorders and abuse. Contraindications for using stimulant laxatives: atony, a bowel that is weak won't be able to respond to the stimulation, and that could then encourage obstruction. Any intestinal obstruction we can't use these laxatives with. And undiagnosed abdominal pain, we need to know what's going on before we assume something is constipation related. Few adverse drug reactions there. Can cause diarrhea, can cause electrolyte and fluid imbalances, blood in the urine, this strange black staining upon endoscopy of the gut lining, and the products, the breakdown products of senna, can cause brownish yellowish discoloration within the urine. Other stimulant laxatives like Docusate, these reduce the surface tension of feces. So it means that water can get into the feces more easily and soften them, helping them to be propelled along. Can be taken as a liquid, as a capsule, but also can be given as an enema as well. And the bisacodal tablets, they can be used to work, which take a little bit longer, or for a quicker action via a suppository, via rectal administration. Glycerin exerts an osmotic effect. It melts and gives this softening effect to fecal matter, which helps it to be removed from the gut, and also a mild irritant effect, which is the stimulant side of things as well. So avoid chronic use. I think I've said that's already for all stimulant laxatives. Not suitable when there's bowel obstruction or acute inflammatory bowel disease or severe dehydration. And remembering that excessive use causes diarrhea and also loss of potassium. Now, with chronic constipation, there could be many potential causes. The obvious things about diet, not having enough fluid for the stool to be softened, the stress coming into things as well. And if there's pain when opening the bowels, that means that the nervous system starts to respond negatively to that and stops people from responding to the defecation reflex. Now, if somebody does get very constipated, the stool can build up and then more liquid stool can flow around it, causing overflow, soiling. Now, with chronic constipation, we can see that we need to manage any underlying cause. Could it be that we need to adjust the dose of a drug that they're already on? What could be slowing it down? Let's think about diet and exercise and so on. Before chronic constipation can be managed, if there's fecal loading, the backup of stool or impaction, which is normally related to fecal loading, needs to be managed first. So a good clear out required first. And if it's opioid-induced constipation, then there is another algorithm, another stepwise management. So we'll come to that at the end. But as you will see here, the stages are essentially the same to begin with: the lifestyle, the bulk forming, the osmotic laxative, and then the stimulant laxatives. But if two laxatives from different classes have been tried at the highest tolerated doses but still fail, there is a drug called prucalopride that can be introduced at that point. And I've got a slide coming up on that as well. So I'm not going to go through how the bulk forming laxatives, the osmotics and the stimulants work, but the bits that we haven't covered are fecal impaction, opioid induced, and procalamide. So I'm going to go to fecal loading and bowel cleaning via osmotic laxatives are normally where we would start with this. So a good clear out over a few days first. And once that's happened, we can then move on, of course, and go through the stepwise algorithm. Now, if we need a fast action, or if somebody doesn't respond to the oral laxatives, it is then fine to consider suppositories, the bisacodal capsules, glycerol alone or glycerol plus bisacodal, an enema such as Docusate or sodium citrate. But we need to warn about diarrhea and fecal overflow happening before the disimpaction is complete. And once that's all gone, we can try and start again. So macrogol is normally started from 4 sachets and then increased every couple of days, usually for 3 or so days. You do have to be able to take in an awful lot of water with these number of sachets, and you need to drink them within 6 hours of making them up. So it might be that a carer comes in and makes something up and they have to have it soon after. For rapid results, you can go down the suppository route. It might be that you want to do something while you're there to help them manage it. It could be that it's pre-surgery and you need to have the bowel cleared before a procedure. If those aren't effective, a phosphate enema can be used once in the morning, but no more than twice a day, or the arachis oil, as long as they're not allergic to peanuts, because that's where it's derived from, and they start working more quickly. People need to know that they are probably going to soil at the beginning, just as part of what we would normally expect to happen. So the role of enemas and suppositories is very much in that sort of slot, in the use for constipation, often to do with fecal impaction or an immediate result. But also where constipation is very severe, they may play a more routine role in managing somebody's constipation. Clearly, if oral agents haven't worked, we need to try something different, and then you could potentially go back to the oral agents afterwards. Around procedures for bowel emptying and where bowel mechanisms are malfunctioning, also to prevent incontinence. Just showing you this again to show we're now moving to the opioid-induced constipation here, and for the prucalamide. Oh, maybe it's the other way around. Prucalopride first then. Prucalopride then is a prokinetic drug. Now, serotonin is highly present in the gut, produced indeed in the gut. You might think about it as the brain more, but it's actually commonly produced and used in the gut as an important signaling molecule, and it helps with peristalsis and secretory reflexes, for example, mucus secretion, and it also helps to signal back to the central nervous system and within the autonomic nervous system about what's happening with the gut environment. And when this serotonin receptor is stimulated by prucalopride, it promotes colonic motility, causes gut contractions, and the dose is different in the elderly, it's lower in the elderly, and this isn't a first-line drug. It is for chronic constipation only. It's usually used for idiopathic constipation where no known cause exists. And a 1 month course, you can see, is fairly expensive. It needs to be taken at the same time every day as part of trying to re-establish bowel habit. Common adverse drug reactions are, as you see there, fairly standard for a drug that's acting on the gut. And it can be continually used and used long-term if it's effective. It's normally checked within about 4 weeks of starting it to see whether it's doing the trick or not. There you go, I had it the other way around. But opioids, the effect of opioids on the gut can be really quite severe. And if we know we're giving somebody a drug like morphine for any period of time, which is highly constipating, as is codeine, or we're in the palliative care situation, we need to think about initiating opioid-induced constipation management even at the start of the treatment with the opioids. And we can see that there are lots of effects on the bowel that we don't want. Increased sphincter tone, which will impair the defecation reflex, reduced peristalsis, which will slow down bowel transit. There will be less fluid within the stool, which means you'll have a dry, hard stool as well. The idea is to avoid bulk forming laxatives and to start an osmotic plus or minus a stimulating laxative with lifestyle changes, and of course look for other reasons as well. It may be necessary to think about how the opioid is used to try and prevent too much constipation with it. The reason for avoiding the bulk forming laxatives is because they distend the colon. And if you are unable to respond to the peristalsis that's then needed, it could lead to a lot of abdominal pain and could even lead to bowel, what's the word I'm looking for? Bowel obstruction, that's the word I'm looking for. Particularly in the world of palliative care, opioid antagonists like methyl naltrexone are used. And the idea of this is that these are opioid antagonists that block peripherally, so they'll sit in the gut receptors and stop the opioid from sitting in those receptors and producing constipation, but they won't cross the blood-brain barrier and they won't have an effect causing opioid withdrawal or impact on pain relief. And the choice of the antagonist will be dependent on things like life expectancy, things like methotrexate or a once weekly injection. There'll be all of the other aspects involved there, as well as cost and patient preferences. There may be the need for more intensive laxative treatments such as enemas and irrigations. Prucalopride pops up there as well, which I've just covered. Linaclonide is quite interesting, and it's licensed for use in irritable bowel syndrome with constipation, because some IBS is more diarrhea related, but where there's constipation as well. So this works as a gut receptor on a gut receptor that maybe you haven't heard of before, guanylate cyclase. And normally this receptor regulates electrolytes and water secretion. And if we agonize this guanylate cyclase receptor, and we improve the intestinal barrier and we reduce inflammation, and that also helps with constipation. So quite an unusual gut drug there for you to consider. Coming to the end now, just bringing this all together, we need to assure our patients that it can take quite some time to restore bowel habit, to get the bowel working more normally. And some people have to stay on constipation meds forever. Others, we will be able to wean off. But that's an important point. We don't just stop them because we can get rebound constipation. We have to gently coax the bowel back into working again. Advising that things can get worse before it gets better, that upsetting things like overflow soiling might occur, urgency and incontinence might have to be dealt with before things can be restored again. We need to try and stop constipation coming back. Some people might need periodic sessions of medications, and this treating the bowel with care and titrating up or down very, very gradually, not just thinking, right, that stool looks normal again, let's just assume that all is well and we'll stop the medicines. Well, I hope that's been a helpful tour through diarrhea, acute and chronic, constipation, acute and chronic. There are some resources that you might care to have a look at. The Royal College of Nursing produces the bowel care professional resource that you see there. The clinical knowledge summaries are always really, really useful for any condition that you care to mention, and I've put the links there for diarrhea and constipation. And there is a nice guideline on managing fecal incontinence in adults, which has some of these drug interventions really there as well for you. Now, upon reflection, when you're thinking about, well, what are the key practice points there for me? Think about what works within your practice, how you tend to manage these issues at home, whether you're maybe directly involved with the administration of enemas and how you can prepare patients for them and give them the longer term view. What clinical prescribing changes might you make? Are you using things in the order, for example, the macro goals, was Laxido first and then lactulose? When is it going to be helpful to introduce a stimulant laxative which is later rather than sooner, and being careful that that's only within a very short period of time? What system or note keeping changes might you make? Maybe that could be the type of safety netting that you're introducing. And are there any additional counselling measures you will consider? Resources, well, I've put some up there for you, but you might have your own ideas about that. And of course, you're very welcome to bring any questions to the live session that we will be having soon. So that is the end of this recording now, and I hope this was useful